Now we'll talk about when the adrenal gland is not working like it should and is underactive. This is called primary adrenal insufficiency, also known as Addison disease. Underlying causes include adrenal atrophy or the destruction of the gland by autoimmune diseases, tuberculosis, or metastatic cancer. Because the aldosterone production is compromised, as you would probably expect, patients present with hypotension. What electrolyte abnormalities might you expect? Right, these patients should be hyponatremic because sodium resorption is decreased. Since aldosterone promotes excretion of potassium and hydrogen, that means they will also have hyperkalemia and metabolic acidosis. For fun, is this an elevated anion gap or non-anion gap metabolic acidosis? This is a non-anion gap metabolic acidosis, and that's because the anion gap is related to measurable anion changes. And for bonus points, what type of renal tubular acidosis is caused by Addison's? RTA type 4, the only type that presents with hyperkalemia. Now, if your adrenal gland is not working well, there's another hormone that we have to be worried about, and that is cortisol. These patients will complain of weakness, anorexia, GI disturbances, and weight loss. A very important sign of Addison's disease is skin darkening. Do you know why this is the case? Well, this takes us back to our physiology lecture. Remember how we said that when cortisol is low, it stimulates CRH release. And CRH leads to the eventual production of ACTH. But how exactly do you make ACTH in the first place? Right, you start with POMC, a large peptide which gets broken down into ACTH and what other two molecules? MSH and beta endorphin. So if you think about this, melanocyte stimulating hormone, or MSH, will stimulate melanocytes. And what do melanocytes do? They produce melanin, which is responsible for skin pigmentation. Something to help you remember this is John F. Kennedy. Remember, he had Addison's disease, and if you look at this picture, you should note his bronze skin. When you have primary adrenal insufficiency, this affects all layers of the adrenal cortex. However, remember, the medulla is not part of the adrenal cortex, so that will not be affected in this setting. Another cause of adrenal gland dysfunction is secondary adrenal insufficiency. This is where you have decreased production of ACTH, which occurs at the level of the pituitary gland. The important distinguishing feature between primary and secondary adrenal insufficiency is that in secondary adrenal insufficiency you do not have skin color changes, and this is because we don't see an excess of POMC production. Also, you will not get hyperkalemia because the release of aldosterone is regulated by angiotensin II and the adrenal gland is not damaged. Now, if primary adrenal insufficiency occurs because of a non-functional adrenal gland and secondary adrenal insufficiency is because of a decrease in ACTH production, what do you think causes tertiary adrenal insufficiency? That's right, it's due to reduced CRH secretion from the hypothalamus. So far, we've discussed primary adrenal insufficiency in its chronic form, such as Addison's disease, but patients can also present with acute adrenal crisis due to adrenal hemorrhage, also known as Waterhouse-friderichsen syndrome, which is associated with Neisseria meningitis, septicemia, disseminated intravascular coagulation, also known as DIC, and endotoxic shock. Of these three etiologies, the link between Neisseria septicemia and Waterhouse-friderichsen syndrome is most frequently tested. A physical exam finding that you should associate with Neisseria meningitis is the classic petechial rash. And in the case of DIC, you will see thrombocytopenia and schistocytes in the peripheral blood smear, as shown here. Coagulation studies should show an elevated PT-INR and PTT, in addition to elevated D-dimer and decreased fibrinogen. Now we'll talk about two tumors of the adrenal medulla. These are the Pheochromocytoma and the Neuroblastoma. Let's start with the Neuroblastoma, which is one of the more common solid tumors found in children. Similar to the Pheochromocytoma, it can occur in the adrenal medulla. However, in addition, it can also occur anywhere along the sympathetic chain. The way the boards will set you up is with a case like this. We have a 3-year-old child who's brought in by his parents because they felt a mass while giving him a bath. You examine him and find a palpable abdominal mass that crosses the midline. He also has spontaneous conjugate saccades during the eye exam and brief involuntary muscle contractions, as well as gait instability. This description is opsoclonus myoclonus ataxia, also known as dancing eyes and feet. Do you know what is the diagnostic test of choice for suspected neuroblastoma? You can look for the breakdown products of dopamine in the urine. Specifically, these are homovanillic acid, HVA, vanillomandelic acid, VMA, which are breakdown product of dopamine. Of note, you will not see norepinephrine or epinephrine because these cells lack the final enzymes that can convert dopamine to these catecholamines. For the same reason, these patients are less likely to develop hypertension compared to patients with pheochromocytoma. There is an oncogene associated with this tumor. Do you know what it is? It is the N-MYC oncogene. Remember N for neuroblastoma. And this oncogene is associated with poor prognosis as it progresses rapidly. Histologically, neuroblastoma is characterized by small round blue cells. Note the blue dots with little cytoplasm that form the Homer-Wright pseudo-rosettes. That's shown here at the arrow. You have these dark tumor cells encircling pale neurofibrils. These Homer-Wright pseudo-rosettes are characteristic of other tumors, including medulloblastomas, pinealoblastomas, and primitive neuroectodermal tumors of the bone, like Ewig sarcoma. The key theme here is that these tumors are derived from neuroendocrine cells. Remember, this is an important association for the boards. So that you can really see what I'm talking about, here are two CT images from a patient with neuroblastoma. On the left, you can see this image has a large mass compressing the left kidney, right over here. And on the right, we see an axial CT where it is crossing over the midline. Our second medullary tumor is the pheochromocytoma. Pheochromocytomas are derived from cells of the adrenal medulla. Do you remember what are the name of these specific cells? These are chromaffin cells. And during embryologic development, what do these cells originate from? Neural crest cells. By now, you must be tired of this question, but it's very important because it's often tested. The major products of pheochromocytoma are epinephrine, norepinephrine, and dopamine. Sporadic secretion of these catecholamines causes episodic hypertension, which is a cardinal feature of this disease. Do you recall how norepinephrine and epinephrine are synthesized? Well, let's go through this in detail. Follow along with me and note the enzymes will be written in blue with cofactors in parentheses. The long names are listed at the bottom for your reference. We'll start with the amino acid phenylalanine, which is converted into tyrosine by phenylalanine hydroxylase. This is further converted into DOPA by tyrosine hydroxylase. Now DOPA, as you remember, is a precursor to dopamine, and is converted by DOPA decarboxylase, which requires B6 as a cofactor. Note how the precursor molecule is the first part of the name of the enzyme that acts on it. Then dopamine gets converted into norepinephrine by dopamine beta hydroxylase, which requires vitamin C as a cofactor. Lastly, norepinephrine is converted into epinephrine by PNMT. Please take time to review this concept again to help solidify it. Be sure to learn the enzymes and the associated cofactors. One great way to do this is to write out the pathway a few times and review it periodically. An important point that you should take note of is this final conversion of norepinephrine to epinephrine occurs only in the adrenal medulla, and this is because it requires the PNMT enzyme, which is only expressed there. This implies all circulating epinephrine originates from the adrenal medulla. Norepinephrine, also a neurotransmitter, can be created by other cells other than the medullary cells. Now let's get back to our discussion on the pheochromocytomas. Do you know what are some of the signs and symptoms? Well, the classic triad for these patients is headache, pain, sweating, perspiration, and tachycardia, palpitations. Additionally, you could have increased blood pressure and pallor. So think P's. So let's say you have a patient who comes in with these symptoms, and you check their blood pressure and it's 165/110. Keep in mind these episodes happen in spells, so it's not like these patients have these symptoms all the time, every single day. Now how would you make the diagnosis? Well, this requires to use what you've learned about the catecholamine synthesis pathway. It turns out you can measure plasma metanephrines, and this is the test of choice in these patients who you have a high clinical suspicion of pheochromocytoma. So let's see why that's the case. If we look here, you will see that norepinephrine and epinephrine are broken down into metanephrine and normetanephrine by COMT or COMT. In addition, other breakdown products such as HMA and VMA are produced. The diagnosis can also be made via urine levels of metanephrines, which are more specific but less sensitive when compared to plasma metanephrines. Definitive management of these tumors is surgical, but patients must get their hypertension under control for a period of months before they can have a safe operation. Do you remember from pharmacology what is the first-line drug you want to use in these patients? An irreversible non-selective alpha receptor antagonist, such as phenoxybenzamine. We do this because if you were to give these patients a beta blocker first to slow their heart rate, then the catecholamines would bind to the alpha receptors and lead to even higher blood pressures, which could have serious consequences such as kidney injury. So after you give the patient phenoxybenzamine, then give the patient a beta blocker to slow the heart rate. You may have also heard of the rule of tens for pheochromocytoma. Pheochromocytomas are traditionally described as being benign, unilateral in the adrenal medulla, and occurring sporadically in adults. The rule of tens gives you all of the rare findings. In 10% of cases, the tumor is malignant. 10% of the time, it will occur bilaterally. 10% of tumors are not in the adrenal gland. Often these will be found in the paraganglionic tissues near the abdominal aorta. Also, 10% of tumors are calcified on imaging. And the reason that this occurs is that sometimes they will produce PTH-related peptide, leading to hypercalcemia. Also, 10% of cases occur in children, and 10% of the time it occurs in families. The familial cases are usually associated with multiple endocrine neoplasias, and these will be discussed in more detail at the end of this section. Okay, time for another flash quiz. A 19-year-old man presents with an 8-month history of weight loss, nausea, loss of appetite, and progressive weakness. Physical exam reveals increased skin pigmentation. What is the likely diagnosis? The patient probably has Addison's disease, or chronic primary adrenal insufficiency. His symptoms are due to insufficient cortisol levels, and the hyperpigmentation is due to increased POMC, secondary to reduced cortisol negative feedback. Recall that POMC is a precursor of ACTH and MSH. In the same patient with Addison's disease, what abnormalities would you expect in the levels of ACTH, cortisol, aldosterone, urine sodium, and urine potassium? ACTH would be high because of reduced cortisol negative feedback. Cortisol and aldosterone would be low due to primary adrenal insufficiency, and urine sodium would be high and potassium would be low because of reduced aldosterone levels.